So we've begun to do some like composite or pooled analyses of the lumateperone data because the larger the sample you have to work with and the more studies that are involved, the closer to the central truth that you can come. And you think each study is a representation of a real scientific truth, but the more research you have, the closer to that truth you might become. And so we now have data from several studies, and so it's a large sample. And these data not only, since the studies were all positive, demonstrating that 42 milligrams of lumateperone added to an ineffective or partially effective antidepressant led to both substantial improvement in patients, both in symptom reduction and the quality of improvement, and in the quality of their lives also. But that improvement generalized to a reduction in suicidal ideation and improvement in their patients' ability to enjoy and have fun and have pleasure, so hedonic capacity. And that the magnitude of the improvement, looking across these studies, was as large, if not the largest, seen in this entire class of treatments. So we not only have, I want clinicians to know that we not only have a new therapy that's been approved for this purpose. Now, lumateperone's been approved for several years for the treatment of schizophrenia, but now it's approved for the adjunctive treatment of major depressive disorder, and that it is effective, and that it's effective relatively quickly, usually by the second week of therapy. There's only a single therapeutic dose, 42 milligrams, so it's easy to get the dose right since there's just one dose. And it's really well tolerated. Very few patients drop out. There's little, if no, weight gain associated with the treatment. Patients are unlikely to have uncomfortable neurologic side effects such as restlessness or stiffness. And you can't ask for much more, honestly. So we're delighted that the results turned out so well. It's not just enough to help them feel better over 6 weeks or 8 weeks or in the short run, but it's really important for the benefits to be sustained and for the treatment benefit not to dissipate, and that means the patient relapses, or for there not to be later emerging side effects. So for example, weight gain can look relatively small in 6 weeks, but over 6 months you can see a lot of weight gain. And so I'm glad to say that in the long-term follow-ups that these studies were paired with, that the benefits were sustained, that people did, on average, continue to improve. If they had not had a full remission with the first 6 weeks of treatment, that could happen with continued treatment. And there was very little cost for the continued treatment in terms of the risk of weight gain or the development of new side effects. Well, so depression is a condition that's defined by the number and intensity of the signs and symptoms of depression that you have and their persistence over time. And so the term remission, which we borrowed many years ago now from our colleagues in oncology, reflects a level of improvement in which there is a profound reduction of symptom burden. So, for example, on the Montgomery-Åsberg scale, the level of symptoms can go from the 30s, but must come down to 10 or below. And so this is a substantial reduction in the symptom burden. But it also, when the level of remission goes down to 5 or 6 or 4 on the symptom scale, that means you're actually at a level in which people who have never been depressed are at. So you've reached not just a relief of symptoms, but a level of remission of symptoms that's comparable to someone who's never been ill. And that sustained over 6 months is what defines a recovery from that episode of depression. Well, the pooled analysis just gives you more confidence in the proportions, and so you can say, very clearly that a certain proportion of people, let's say a third, get don't, unfortunately, just don't get a substantial benefit, and we need to keep looking for other treatments to help those. But the remainder of the patients, whether they receive the medication in an initial treatment trial or whether they receive it second after getting placebo in a controlled trial, that the majority of patients respond to this treatment, and a substantial proportion of those who respond reach a remission level, particularly over the 6 months of continued treatment. Well, since we're not using this to treat antipsychotics, we're still working on finding a new name for when we use medicines originally discovered as antipsychotics for this purpose. But compared to the other adjunctive therapies, this is the top of the line. There are no other adjunctive therapies that come from the antipsychotic medication class that have better data. These are the best data that there are out there.